Hello, this is Angelia, and you're listening to or watching the podcast, Why You Do What You Do. Podcast that talks about human development and psychology to maybe help you figure out a little bit more about why you do what you do. And we've been talking about death, and we're going to continue that. Like I say, I hate to let you know you're going to die someday if you're alive, but you are. So we're going to start talking about dignity-conserving interventions for patients nearing death. And like I say, there are a lot of good hospice workers out there, and if that's something that you'd be interested in doing, they're much needed people. So we're going to talk about the factors, the subthemes, dignity-related questions, and therapeutic interventions. So for illness-related concerns, symptom distress, physical distress. How comfortable are you? Is there anything we can do to make you more comfortable? And you can have vigilance to the symptom management, frequent assessment, and application of comfort care. And the concern might be psychological distress. You can ask, how are you coping with what is happening to you? And for interventions, you can assume a supportive stance, empathetic listening, and referral to counseling. And a lot of times, empathetic listening is about all you can do. Concern for medical uncertainty. You can ask, is there anything further further about your illness that you would like to know? Because I know I ask questions. Are you getting all the information you feel you need? Because sometimes you don't. Sometimes they're just like, meh. And the intervention could be, upon request, provide accurate, understandable information and strategies to deal with possible future crises. Death anxiety, which pretty much everyone has. Are there things about the later stages of your illness that you would like to discuss? And then the same thing, give them information if they have questions. Level of independence or dependence. You can ask, has your illness made you more dependent on others? And help might be have patients participate in decision making regarding both medical and personal issues. And a concern might be cognitive acuity. You could ask, are you having any difficulty with your thinking? And most people will be honest when it comes to that point. And you could treat delirium when possible, avoid sedating medication, because you don't want them to be just sleeping all the time and missing what time they have left. Concern might be functional capacity. You might ask, how much are you able to do for yourself? And help might be use orthotics, physiotherapy, and occupational therapy, because they might want to be able to still be as independent as possible. Dignity-conserving repertoire, dignity-conserving perspectives, continuity of self. Are there things about you that this disease does not affect? You can acknowledge and take interest in those aspects of the patient's life that he or she most values. See the patient as worthy of honor, respect, and esteem. Role preservation might be a concern. You could ask, what things did you do before you were sick that were most important to you? Ugh. A concern might be maintenance of pride. You could ask, what about yourself or your life are you most proud of? A concern might be hopelessness or hopefulness. You could ask, what is still possible? And an intervention could be encourage and enable the patient to participate in meaningful or purposeful activities. A concern might be autonomy or control. A question you could ask would be, how in control do you feel? An intervention might be involve the patient in treatment and care decisions. A concern might be generativity or a legacy. A question you could ask, how do you want to be remembered? An intervention could be life project, such as making a audio or video cassette, writing letters and journaling. Dignity psychotherapy. Sometimes people need a little help to get this wrapped in their head and, have their head wrapped around it, and, that could be helpful. Concern might be acceptance. You could ask, how at peace are you with what is happening to you? An intervention might be support the patient in his or her outlook, encourage doing things that enhance their sense of well-being, such as medication, light exercise, listening to music, or praying. A concern might be dignity-conserving practices, living in the moment. A question you could ask are there things that take your mind away from illness and offer you comfort? An intervention might be allow the patient to participate in normal routines or take comfort in momentary distractions, such as daily outings, light exercise, listening to music. A concern might be finding spiritual comfort. You could ask, is there a religious or spiritual community that you are or would like to be connected to? An intervention might make referrals to chaplains or spiritual leaders, enable the patient to participate in particular spiritual and or culturally based practices. Concern might be social dignity, privacy boundaries. You could ask, what about your privacy or your body is important to you? An intervention might be ask permission to examine the patient, proper draping to safeguard and respect privacy. A concern might be social support. A question you can ask are, who are the people that are most important to you? Who is your closest confidant? And a intervention might be liberal policies about visitations, rooming in, enlist involvement of a wide support network. A concern might be the care tenor. Question you could ask is there anything in the way you are treated that is undermining your sense of dignity? An intervention might be treat the patient as worthy of honor, esteem, and respect. Adopt a stance conveying this. A concern might be a burden to others. I hear that a lot. A question might be, do you worry about being a burden to others? If so, to whom and in what ways? And a intervention might be encourage explicit discussion about these concerns with those they fear they are burdening. A concern might be aftermath concerns. A question you could ask is, what are your biggest concerns for the people you'll be leaving behind? And an intervention might be encourage the setting of affairs, preparation of an advance directive, and making a will and funeral planning. And that way the person, can come to terms with the things. And sometimes, of course, that's if the death is a slow process. Most people don't get that. Most people are gone, and you don't get that. So this is an optimal, situation here, from when you first know to the point where you're going, and you would have time to do these things and take these steps. And like I say, this is a thing that hospice workers are trained to do. And like I say, it's a really good job. If you feel you had the heart for it and you could take it, in your heart. I couldn't take it. It would be too much for me. But the world needs more hospice workers. Palliative care is not only for the very old. Hospitals and medical professionals around the country are developing protocols for pain-free treatment of dying newborns whose lives cannot be saved. And I mean, I think that's a blessing, and those people are going to be blessed for, doing that for those poor little babies who, get hours or moments of life. Facing death and loss, psychological issues. What changes do people undergo shortly before death? Because there are some. How do they come to terms with its imminence? Because let's face it, like I said, if you were born, you're going to die. How do people deal with grief? Everybody's different on that one. The answer may differ for different people. Confronting one's own death. And like I said, if I'm the first one to tell you you're going to die, I'm sorry. In the absence of any identifiable illness, people around the age of 100, close to the present limit of the human lifespan, and that's the medical human limit. In the Bible, it says the years of man are 120. So that's what I say. I'm planning on going to 120 till God tells me different. Usually suffer cognitive and other functional declines, lose interest in eating and drinking, and die a natural death. And that's usually how it goes. You start forgetting stuff. You're not able to do stuff like you used to. And then you just don't feel like eating and drinking. And, that's usually when the body starts to go. Such changes also have been noted in younger people whose death is near. So it's just not old people who die, unfortunately. Some people who have come close to death have had near-death experiences, often involving a sense of being out of the body and visions of bright lights or mythical encounters. Now, when I had my first heart attack, I had an out-of-body experience. I went up the tunnel of light, like you hear about. There was 2 angels at the end of the tunnel, and they said, "It's not your time yet. You can go back if you want to." And I was like, "Oh, okay." And I turned around and came back to my body, and that's when I woke up and was like, "Okay, dear, I think I just had a heart attack," and went to the hospital and got the thing shot up in me and all that kind of fun stuff. And like the second one, not so much. It was just a pain, and I was like, yeah, it's going through. This is a problem. We need to go. So, and I've had other, dreams of talking to angels about things. And I know people, like I said, my sister came and saw me one night when my house was getting ready to burn up. My old heater that we used to have was electric, had fans on it. And it was, it had burned out and it was smoking. And I was laying in bed, and I hear my sister's voice at the headboard. It's like, Ange, and I was like, Mary? And she's like, yeah. And she said, wake up, you're on fire. And I was just like, meh, and laid down. And then I saw, like, in my dream, my china cabinet flying up in the air, like with a blast and fire coming out. And then the next thing I know, she's beside the bed near, the other pillows. And she said, Ange, get up. You're on fire. And then I woke up, and sure enough, my room was filled with smoke. So, I believe there's another side, and people can come if, like I said, when I was 4, my great-grandma came, and she said, I had to get permission. That's why these 2 men, I called them the bird men, now I would call them angels, were with her, to come talk to me. So I believe there's something past, this body. I believe that 100%. So, if you don't, maybe it's time to start reading your Bible or whatever book, your culture has, and, maybe it's time to start looking into things, because I'm pretty sure, 100% sure, that there is something past this. There are sometimes interpreted as resulting from physiological changes that accompany the process of dying, or psychological responses to the perceived threat of death. And some people say that's the case, but I feel like that would be a gradual thing then, not an instantaneous thing. So, I mean, I don't quite buy that assessment, because, like I said, I've had one myself, so I know it felt very real to me, and it wasn't like, a dream. Like, dreams are kind of hazy, and, even a lucid dream is, nonsensical sometimes, but these things made perfect sense, and were very more than lucid, I would say. I could know what I saw, felt, smelled, or whatever. So, like I say, I think there's something out there. The psychiatrist Elizabeth Kubler-Ross, in her work with dying people, found that most of them welcomed an opportunity to speak openly about their condition and were aware of being close to death, even when they had not been told. So, like your animals know, like your dog might curl up somewhere or want to put their head on your lap, or your cat might disappear into a closet or whatever, or come to lay on your lap, depending on what type of cat you have. So animals know, and we are animals, we're not vegetable or mineral. So sometimes we kind of know too. And depending on whether you want to be with someone or alone, you'll probably make that happen so that you're in the position you want to be in when you go. After speaking with some 500 terminally ill patients, this thing is coming out here on me. It's not comfortable. Let's see. Kubler-Ross outlined 5 stages in coming to terms with death. Number 1, denial. The refusal to accept the reality of what is happening. And that's what a whole lot of people do. Number 2, anger. Number 3, bargaining for extra time, sending up them prayers. Lord, I gotta live longer. I gotta do this. I gotta be there for the kids, grandkids. You start bargaining. Number 4, depression. Yep. And ultimately, number 5, acceptance. She also proposed a similar progression in the feelings of people facing imminent bereavement. So, it's coming and you have the same feelings as the person going, but, it's a little more personal to them than it is to you, honestly. Kubler-Ross's model has been criticized and modified by other professionals who work with dying patients. And that's because, like I say, everybody's different and there's no one set rule. There's the law of averages, but there's always exceptions. Although the emotions she described are common, not everyone goes through all 5 stages, and not necessarily in the same sequence. So, not everybody's going to reach acceptance. Not everybody might be depressed or sad. They might be ready. I know people who have been ready to go. So, like I say, everybody's different. And living is an individual thing, and so is dying. A person may go back and forth between anger and depression, for example, or may feel both at once, which, I certainly did, when I got my diagnosis in my 40s, and it's like, okay, this sucks. Are you telling me I'm not going to, be around for my children to grow up and everything? I'm too young for this. This is crazy. Why did this happen to me? What is going on? Did I do something? Should I have done something different? And, you ask yourself all these questions like this. Unfortunately, some health professionals assume that these stages are inevitable and universal, and nothing is. Nothing is. And others feel that they have failed if they cannot bring a patient to the final stage of acceptance. And if any doctors are listening to this, don't feel that way, because everybody's different, and there are going to be people who just are not going to accept the fact that they're going to die, and that's not your fault. That's just their stubbornness, honestly. Dying, like living, is an individual experience. For some people, denial or anger may be a healthier way to face death than the calm acceptance that Beth seemed to exemplify in Little Women. Because, like I said, some of us, go at peace. Some of us go fighting all the way. Kubler-Ross's description, useful as it may be in helping us understand the feelings of those who are facing the end of life, should not be considered a model or a criterion for a good death. Because, like I say, everybody's different. Patterns of grieving. Bereavement, the loss of someone to whom a person feels close, and the process of adjusting to it, can affect practically all aspects of a survivor's life. And if you've ever lost anybody close to you, you'll know that. Like I said, my sister I lost when I was 17. I was in denial. I was like, that's not going to happen. God's going to pull out a, Hail Mary there, and there's going to be a miracle. She's going to get out of there. She might have some work to do afterwards, but she didn't. She passed away. And then my grandmother, I was like, okay, this, she's going to get better. She's beat these things a few times, but she didn't. She passed away. And then my mother was just she had a heart attack, and she felt a little better and got a little better, and then, 2 months later, she passed away. So, like I say, it's not always a sequential thing. Sometimes it just happens when it happens. Bereavement often brings a change in status and role. For example, from a wife to a widow, or from a son or daughter to an orphan. And I wouldn't consider you being an orphan if your parent is passed. I have a little dispute with that. You had parents, you weren't, given away. So, it may have social and economic consequences, a loss of friends, and sometimes of income. But first, there is grief, the emotional response experienced in the early phases of bereavement. And we all feel grief at any loss. Grief, like dying, is a highly personal experience. Today's research has challenged earlier notions of a single, normal pattern of grieving and a normal timetable for recovery, because everybody's different. You can't just pin everything down. It'd be great if you could, but you can't. Some people tried. It doesn't work. Sorry. A widow talking to her late husband might once have been considered emotionally disturbed. Now this is recognized as a common and helpful behavior. Although some people recover fairly quickly after bereavement, others never do. And again, it's got to do with the closeness of the bond and the resilience you have. Perhaps the most widely studied patterns of grief is a 3-stage one, in which the bereaved person accepts the painful reality of the loss, gradually lets go of the bond with the dead person. And I don't believe you ever have to do that. I don't believe you ever have to let go of the bond with the dead person. I don't believe you should be spiritualists, have seances, trying to contact them and stuff. But you can still hold that person in your heart. And there was a bond there, and you don't have to let go of the bond and pretend it never existed and let that person go. You can still have that bond with that person. They're just not here anymore. They're elsewhere. And readjust to life by developing new interests and relationships. This process of grief work, the working out of psychological issues connected with grief, generally takes the following path. Though, as with Kubler-Ross's stages, it may vary. Because, like I say, no two people are the same. So, we're all snowflakes. And I know there was a section of society that used that as an insult. But it's not, because we are all different and unique. So actually, to be a snowflake is a good thing. So shock and disbelief. Immediately following a death, survivors often feel lost and confused, because this person was a part of your life and now they're not there anymore. As awareness of the loss sinks in, and you've heard that, I know people, it hasn't sunk in yet, and you hear that at funerals and afterwards, it hasn't sunk in yet. Excuse me. The initial numbness gives way to overwhelming feelings of sadness and frequent crying. And that is 100% true. This first stage may last several weeks, especially after a sudden or unexpected death, or even months or years. Preoccupation with the memory of the dead person. In the second stage, which may last 6 months or longer, the survivor tries to come to terms with the death, but cannot yet accept it. A widow may relive her husband's death and their entire relationship. From time to time, she may be seized by a feeling that her dead husband is present. These experiences diminish with time, though they may recur, perhaps for years, on such occasions as the anniversary of the marriage or of the death. There are people who think that their loved one is still present in spirit in their home and talk to them and things like that. Resolution. The final stage has arrived when the bereaved person renews interest in everyday activities. Memories of the dead person bring forth feelings of fondness mingled with sadness, rather than sharp pain and longing. And I think that is a good goal, where you remember them fondly and you celebrate the relationship that you had, because trying to forget them, put them behind you forever, I don't think is healthy, honestly. Although the pattern of grief work just described is common, grieving does not necessarily follow a straight line from shock to resolution. One team of psychologists reviewed studies of reactions to major losses, such as the death of a loved one, or the loss of mobility due to a spinal injury. And like I said, any bad thing that happens to you is going to cause you grief. There's just grief, degrees of grief. Small grief where you misplaced something, to large grief where someone in your life is not there anymore. These researchers found some common assumptions to be more myth than fact. And like I say, everyone's different, so everyone's grief is different. So it's hard to have a ruler and say, okay, you got to do this, that, and the other thing. Those are guidelines. And you might have feelings that are common, and you might have feelings that are uncommon. And generally, that's why they have grief counseling, is if you feel like you cannot get over someone's death or something that has happened to you, it's a good thing to go and talk to someone and get that garbage taken out and get that hashed out, so that you can move on with your life. Because anything that's affecting you or the people around you is a problem, and you need to go talk to somebody and get that garbage taken out. So that's where I'm going to leave you for today. I hope that helped you figure out a little bit more about why you do what you do. Please like and share this educational program so we can spread it around the world. If you want to help me out, subscribe to my YouTube channel. If you want to help me out even more, go to my Patreon page and become a patron. Thanks for watching or listening. That's all for now. Until next time.